Good evening and good morning to everybody, and thank you to be here in this last webinar of asthma organized by Global Asthma Association. Today, the topics of the presentation will be focused on the perception of severe asthma and clinical management of severe asthma. And in order to speak on these topics, we will have an important key opinion leaders on this topic that will be Professor Fulvio Braido from the University of Genova, Italy. And we know that Fulvio Braido is a very important scientist in terms of disease perceptions and asthma management. But before to start with the presentation, I want to underline you that this webinar series has been organized by Global Asthma Association, an important scientific association on asthma that focus the activity on the comprehension of asthma in terms of scientific basic clinical management, new therapy, and improvement in clinical management. So I encourage you to adhere to this association in order to have an improvement for knowledge on asthma. And so in the end, I want to underline also that in the end of this year has been organized an international meeting by Global Asthma Association on asthma in Avignon, France. And I hope that all together have the possibility to adhere and to participate in this meeting. So now I have a pleasure to introduce the speaker, Professor Fulvio Braido. Please, Fulvio.
Thank you very much, Professor Santus, for introducing me in this webinar. The topic of this session is quite intriguing because we are looking at the perception of severe asthma and its treatment by the clinician. And when we look at the literature, only a few evidence are available on this topic. In the next minutes, I will divide my presentation in two parts. The first related to the perception of severe asthma, and the second one based on the perception of treatment, especially with the focus on biological treatment from the physician perspective on the basis data coming from the Interasma Global Asthma Association research. But I would like to start with this data coming from IQVIA, that is an analyst of the market of treatment well recognized worldwide. They were published on May 2020 this analysis, and they analyze and they stated that looking at the next decade, the biological use, biological treatment in asthma will change our behavior. It is clear that nowadays the global asthma market value in biologics is about 20% of the overall market, but it will doubling. Will be the doubling of this share in the next 10 years. And we have also to consider that we have new drugs, but on the other hand, we have to consider that we have at least 17 inhaled molecules that we use for treating our patient that will lose the patent protection in the year from 2020 to 2029. They stated that the global market of asthma will reach the 29 billion in 2029. That means a 59% increase from 2019. And this growth will be related to the approval of new therapies, but in the same time, in the same year, we will have the loss of patent of some of the currently available monoclonal antibodies. And in this slide, you can find reported the expected impact of the launch and the expected impact of the law of patents of the molecule. And you can see that the launch will have a major impact than the law of the patent. This means that also the availability of the drugs, but also our behavior will change. You can find a report what happened from 2014 to 2019, and you can find that the value share of inhaled products decrease, while at the same time a significant increase of prefilled cylinder or vial of biological products has been identified. And again, when we compare the 2019 to 2029, a further increase of the biological is clear. Starting from this point, I believe that you can consider some topic that today, although we have had the first biological treatment for asthma at least 15 years ago, the use of biological in respiratory section is still limited. The counterpart is still a significant use or maybe a overuse of oral steroid, and we have a lot of evidence about the related side effect and the unsafe profile of this drug and the possibility to avoid this kind of treatment for our patients. And finally, when we look at the asthma outcome, we are not completely satisfied about the outcome. In other words, there is a gap between the evidence that we are able to achieve in the context of a randomized trial, exploring the efficacy of the drug, and the real life. I believe that we have to analyze this point in order to better understand how we can manage and how we can improve our mode of action. And I will start on considering some point about the perception of severe asthma. And about 12 years ago, has been published in ERJ this paper, and the author, the coordinator of the work was Ellen Raddell. In this work has been clearly distinguished the severity and the control. And the severity is the amount of treatment required to maintain the control of the disease, and the control is a distinguished concept. And refer to the ability of the drug to improve the health status till a level that is similar to the healthy subject. I believe that this point needed to further improve the real life, but a lot of things has been done in the past decade, and we all know the efficacy of using the control as a composite outcome measure for reaching the well-being of our patients. We move about 20 years ago from the analysis of a single outcome to the analysis of a composite outcome. And inside the concept of control, there are the daytime symptom, the nighttime symptom, the limitation of the activities, the use of rescue medication, and for some tool, the lung function. Obviously, the concept of control is more related to symptom, is a little bit far, is not inside the tool, the assessment of the exacerbation, that is part of the future control, as mentioned by Gina, but there is a close relationship between the level of control and the probability of asthma exacerbation. We are aware that we can reach the total control in our asthmatic patient. I would like to mention for this the GOLD study that is a cornerstone in research published in 2004, showing for the first time that with the drug available at that time, that means ICR, also ICS plus LABA, we are able to reach the total control in about 40% of our patients. And when we accept some limitation of the disease, we are able to achieve a good control in about 70% of our patients. This is what's happened in the context of a real life, in the framework of a randomized control trial. But it's not so simple to achieve these results in real life. One of the major points is the ability of the physician to intercept the need of the patient and to provide a plan for long-term plan for treatment and control of the disease, aiming to achieve the best possible control. I believe that this is one of the last or largest evidence about the level of control, at least in Europe. We are in the context of a cross-sectional perspective longitudinal observational trial. And as you can see in this observation have been enrolled more than 8,000 of patients coming from at least 15 countries in Europe. And you can find that this is the picture. We have 43% of controlled people, 18% of partly controlled, but we have still 39% of uncontrolled people using one of these above mentioned validated tool, in this case, the ICQ. The situation is different among countries. You can find here the smile for Italy and Spain, but a sad face for some other countries. And when we provide a ratio between controlled and uncontrolled people, you can find that you have a few countries where the number of controlled people is greater than the number of uncontrolled people. I believe that this picture needed to be further explored in terms of sensibility of the physician in targeting for control, but also the availability of drugs that is different among countries, and also the awareness of the disease among the general population. And I believe that there is a greater room of improvement considering this point. I still believe that the tool, the concept of control is of great interest. I like this paper published on BNC Pulmonary Medicine 2020, where the relationship between asthma control test and other outcome has been reviewed. And you can find here reported that a correlation or an association between control as other relevant issues, such as the rescue medication, the number of exacerbation, the lung function, the quality of life, the sleep quality, but also the work productivity and the use of healthcare reserves, has been reported, and we have clear evidence that this kind of tool is able to provide not only a picture about the clinical level, but also is relevant in providing the evidence of the benefit that we can have on other issues, such as the use of healthcare reserves of the work or school productivity that seem far from the control, but are strictly related to this concept. But again, when we use a tool, we have also to know the potential limits of this tool. And this has been explored in this paper from Australia and China. And they analyze the sensitivity and the specificity of ACQ and the ACT in analyzing, in assessing controlled asthma, not well-controlled asthma, and uncontrolled asthma. In the right part of this slide, you can find that when we analyze, we use the ACT in controlled people with asthma, the sensitivity is about 70%, and the specificity is about 90%. But when we analyze the sensitivity of ACQ is lower than ACT, and especially when we analyze the sensitivity in non-controlled and especially uncontrolled asthma, the degree of sensitivity is really lower. And again, similarly, the specificity remain high for this kind of tool also in not controlled asthma and uncontrolled asthma. The implication of this point is that when we use in clinical practice the ACT is better than ACQ, also because the second one require other investigation. But when both of this kind of tool are not so useful in assessing uncontrolled asthma. In other words, we need some more specific tool, sensible tool in order to further improve our sensibility in discover uncontrolled asthma. This is the first point. The second point could be related to the patient. Some years ago, we performed this kind of analysis using a large sample of Italian general practitioners and their patients, more than 7,800 patients. And as you can find in a report, when we define the ranking of topics that could be relevant for the patients, at the first point, the patient state the meaning of asthma control. In other words, they really know the asthma treater, they are aware of what they have to do in case of asthmatic attacks, but they need to know which is the really concept of control, which is the level of well-being that they can achieve with a proper treatment. I believe that we have to bear in mind this point for the future, because we have the drug, but we have to tailor our mode of action according with the reality, and the reality is that we can achieve the total control of the disease. I would like to finish this part of my presentation. Remember to you the severe asthma definition stated by ATS-ERS in 2014 refer to the level of treatment, both in terms of inhaled drugs, but also the use of oral steroid for some part of the year. And they define uncontrolled asthma with one of the following issues: the poor symptom control, the frequent exacerbation, the seriousness of the exacerbation, the airflow limitation, and also the severity is related to the ground necessary to achieve the control. But we have also to consider that is severe the patient that whose control of asthma can be worsened on tapering by the high dose of ICS. Starting from this point, we have launched a survey in the context of Global Asthma Association, exploring the ability of the physician to clearly identify patients with a disease of different severity. How do you consider these were the question that we provide to the audience? How do you consider a patient on long-term treatment with high dose of ICS LABA presenting one exacerbation in the previous year requiring 3 doses of ICS and a FEV1 at 70% of the DICT? Or how do you consider a patient on long-term treatment with high dose of ICS presenting ACT score below 20 or an ACQ greater than 1.5 and the FEV1 90% predicted? And you can find here reported the answer of the sample, and we're able to clearly identify the level of severity about 50% of our colleagues. This means that the concept of control, the use of tool, the sensibility of tool, the awareness of the patient about the control needed to be ameliorated if we needed to improve the outcome of asthma. It is clear that we have to distinguish this severity that is characterized by the impact that the disease process has on the utilization of reserve comorbidities and also to measure outcomes such as mortality, from the perceived severity or perceived seriousness that refer to the negative consequences associated to a potential outcome. I believe that this content need to be further clarified, object of information and education also, because the severity is strongly related to the behavior. And in this part of my presentation, I would like to present you the results of a survey that we performed in the context of global asthma about the belief and behavior about biological treatment. Starting from this point of view, that the perception of the therapy is at the crosslink of several issues. First of all, the clinical picture, but also the frequency, duration, and efficacy of a therapy, the health facilities and the possibility to achieve healthcare, drugs, and so on, but also is at the crosslink of some other issues related to the patient, such as the patient knowledge about the disease, but also cultural and religion-related factor, the social network, the family and the world, and the environment, the context where the patient lives. We, as mentioned, we believe we explored this issue in the context of this survey on belief and behavior by biological treatment for disease asthma, developed by ISNESNet. ISNESNet is the Interasma scientific network. Is a cohort of colleague coming from different parts of the world involved in scientific activity related to asthma. And we developed this survey in 2019, has been published in 2020. At that time, this was the availability of biological drugs for severe asthma in the world. We have some country with 5 biological drugs, but also other country with in which only omalizumab were available. The availability of biological drugs. We involved in the survey people coming from 37 countries of 4 continents, and we published these results on the World Allergy Organization journal in 2020. Anders Beacon from UK was the first authors, but several people coming from different countries were involved. we collected more than 300 of questions coming from 300 people involved in prescription of biological drugs in the treatment of severe asthma. 285 valid questions were available at the time, were available for analysis. Look at our sample, the majority were male with a 57%, with a mean age of 47. And looking at the specialty, 45% of pulmonology, 18% of internal medicine specialist, and 30% about 30% of allergists, and 6.7% of pediatrician. The mean age was, as you can find here, reported the larger representative of the sample. And when we analyze the geographical distribution, as mentioned before, we have people from 37 countries, but the majority of them are coming from high-income countries with 44%, and 47% from upper middle income country, with only 80% coming from lower middle countries, according to the World Bank. And 70% of the sample were coming from Europe, but we have also a significant representative of South America, at the first point Argentina and Brazil. And in Europe, besides Italy, we have a significant presence of Turkey, Hungary, and Bulgaria, and Romania, and so on. We have analyzed which kind of a drug, of biological drug, were available at the time of the survey. We were at the middle of 2019, end of 2019. In the majority of cases were available omalizumab, but in some cases, in a lot of countries also mepolizumab. It was at the beginning of the launch beralizumab, and in a few countries arelizumab. As mentioned before, we have answer only coming from prescriber of biological drugs, and the majority of them report some bureaucratic limitation in the prescribing this kind of drugs, and this must be taken into account in analyzing this point. We were in 2019, this is the flowchart of GINA 2020. At the time, the step 5 treatment of GINA is here reported, and the biological drugs in terms of anti-IgE or anti-IL-5 or anti-IL-5 receptor were suggested as first line and before the use of OCS. Looking at this picture, we have to consider that the drug availability can interfere with the behavior and the perception of efficacy and safety, although an extensive literature of the other drugs were available at the time of the survey. You can find reported that 37% of countries omalizumab was the only available drugs, while in 40% both omalizumab and maple were available, and 22% Berra and Relis were also available in addition to omalizumab. 76% prescribed only omalizumab, while 24% omalizumab plus another anti-IL-5 molecule. These are the characteristics of the sample, and 70% of the prescriber tended to use the biological drug instead of oral steroid, in addition to ICS LABA inhaled treatment. And 28% of prescribed biologic for patients on oral glucocorticoid steroid with the aim of tapering their dose down. I believe that this is quite significant, because there was at the time a change in the suggestion for prescription of biological drugs, and the unsafe profile of the oral steroid raises some interest at the time of the sample. Some other info coming from the survey. 54% of respondents believe that the efficacy of oral glucocorticoids can predict the efficacy of the biological drugs. As you can see, is the majority, but we are not so far from the 50%. 22% disagree with this opinion that steroids are not the effects of steroids cannot predict the efficacy, and a quarter of the sample had not formed an opinion on this topic. We are in the context of Th2 and now T2 inflammation. It is clear that the efficacy of the inhaled steroid and oral steroid, but you can find here the perception of the sample explorers. And looking again at the relation between a biological and oral steroid, the 72% of physicians believe that the efficacy of biological drug exceed their potential side effect, and the 74%, this means 3/4 of the sample, state that they are safer than long-term treatment of 5 milligrams of prednisone, while 1 out of 2 of the physicians, of the specialists involved, consider the potential adverse events are less than 3 short-term bursts of prednisone. I believe that it's quite clear that the biological have a great safety, but on the other hand, we are 2 years later and the use of steroid is still evident in the behavior of, in our behavior. A key point is, since we have some molecules, we have further molecule in this next year, is quite interesting to analyze the perception about the property of the different biological treatment in order to analyze the criteria for the selection of the different drugs. And we provide this kind of question, which is the first biological parameter that you consider in patients with severe asthma. And at the time, the allergic status was the dominant ones with 79% of the preference, and the blood use was only 25% of the answer. And looking more in detail at this phenomenon, you can find a report that 79% of the people state that in a patient with severe asthma, sensitization to allergens and blood use more than 300, the first time at that time was omalizumab. We have to remember that this drug was on the market from several years. The experience the physician got was greater than with the other drugs. You can find a report that the different percentage, but you can find also that the MAPLE was the second drug introduced, gained in a short time the consideration among the physician. Another point was the threshold of blood use and sputum rate of EOS in analyzing the feature of the patient in the selection of the drugs. You can find a report that 72% of the respondents considered more than 300 cells, blood cells, significant, while only 10% aimed for ABOs greater 150 cells. And on the other hand, look at the sputum, only 52%. That's mean an half of the population considers significant eosinophilia in the sputum greater than 3%. This means that while for the EOS, the 300 is well considering the sputum, only an half of the population have a preference concerning the rate of EOS that could be considered significant. And which we request to the physician to answer to this question: which one among the following you consider the faster in ameliorating the clinical status? And you can find a report that the first place at that time was OMA, but at the second place the MEPO. Only few people had the possibility at the time, but they based their opinion only on the evidence coming from the literature, and 10% selected the barrel, and 3% the Leslie drugs. I believe that the differentiation among compounds from drugs concerning the mechanism of action is a matter of interest, and 43% of the respondents were aware that IL-5 and IL-5 receptor have different pharmacological effects, while at that time, that means about 2 years ago, or less than 2 years ago, 38% did not have yet an opinion on this topic. And this is crucial in order to achieve or to change the perception about the biological drugs. And we have also explored the route of administration, asking, for example, which is the more effective and which kind of treatment the physician prefer. You can find a report that comparing intravenous and subcutaneous, at the time Leslietumab was launched only in a few countries, the people considered that subcutaneous is equal to intravenous administration in the majority of case, and exploring the preference for a tailored dose or a predefined dose, or the people that participated to the survey, in the 75% of the cases, considered that the tailoring was the preferred ones. But maybe this behavior has been changing in the last 2 years, and they also clearly define that the selection of the route of administration is a part of the personalization of the treatment plan, and this refers not only to the dose and to the administration way, but also to the schedule of the treatment. Some other issue coming from the survey, for example, as mentioned before, the majority of physicians prefer a monthly administration, less a biweekly administration, a significant part a bi-monthly administration, and this is what the physician consider relevant for the patient, but also the schedule that the doctor prefer is similar with the monthly administration, with a more number of a greater consensus than a monthly administration, at least at the time of the survey. Which is the rule of biological, which is the biological effect of the drugs? Do you believe that anti-IgE is able to reduce the EUs? Do you believe that an anti-IL-5 is able to reduce the IgE? These were the questions. This you can find here reporting the results. 33% of participants believe that anti-IL-5 molecules can reduce the IgE, while 54% that omalizumab is able to reduce the EUs. You can find here reported that the percentage is not 80%, the rate of answer is not 80 or 90%. This means that there is the need of further information about the ability of the different drug in achieving this kind of goal. But another key point, and a strategical point, is the ability of the drug, of this kind of drug, to modify the natural history of the disease. And At the time of the survey, only 50% of the patient believes that on my anti-L5, Dupi was not available at the time of the survey in any country. Only 50% of the people consider this kind of potential disease modifier. Some final consideration about the biological steroids. 72, as mentioned before, consider that they are safe, better than steroids, but when we ask if they consider these patients severe and suitable for a biological treatment, exploring these two cases, as you can find here reported, only a minority of people consider this patient severe, although they were according with the data provided. This is the relationship between the behavior between the biological drugs in terms of safety, efficacy, availability, and so on, and the perception of severity of the clinical picture that the physician has in mind. And coming back again to the treatment, of the result of judgment of the efficacy of the treatment, we asked the physician which kind of time span they consider enough for judging the efficacy, and the majority refers 6 months. And on the other hand, which kind of clinical parameter they consider the most relevant for assessing the efficacy of a biological treatment. And you can find that at the first place, there is the exacerbation in 6 months, a target of the majority of the clinical trials performed in the last year. But at the second point, a clinical relevant issue that is the tapering of stopping of oral steroids. Exacerbation at 6 months, the most important, 7 physicians out of 285 consider the exacerbation rate the most relevant issue, followed by tapering of steroid and ICT score. And the combination of these three parameters can guide their daily practice. The majority of physicians consider that 6 months of treatment are enough to judging the efficacy. You can find that they are sure about this 53% of physicians, while 26% consider that 3 months are enough, while 20% of the sample consider that they have to wait for 12 months in order to have a more complete judgment about the efficacy of the drugs. I believe that we have a lot of input for those. We have to consider, and could be, we will propose again this kind of survey 2 years later. We have a lot to change in this before the pandemic event, but also during the pandemic event. We have the launch of dupilumab with a larger possibility of use in T2 patients. We have new data concerning the ability of all the biological treatment in reducing or stopping the oral steroid. We have now safety, more data on the safety profile and on the long term, 3, 4, and so on, years of follow-up of patient treated with biological drugs. But we are a significant pipeline in the field of the biological treatment. And again, I believe that we have reconsidered the perception that we have about this term severe asthma. we have to reconsider the tool that we are using, and maybe we can use we can adopt some results coming from the artificial intelligence that will provide us the tool for analyzing a lot of data coming from now by our clinical database in order to improve the sensibility and specificity of the available tool in identifying unmet needs of our patients. It is clear also that the perception is related to the use of the drugs and also the modality of the use. With the pandemic event, a lot of patients were moved to the self-administration of the drugs, and all the available drugs are moving far from the hospital to the home of the patient. And also this change in our behavior must be considered in order to have further information for a better and safer treatment of our patient. I would like to thank you for your attention. I would like to invite you to be part of Interasma Scientific Network, that is a close community working inside the Global Asthma Compassion. Is free, obviously. You can contact the Secretary of Interasma. We have developed a network, a collaborative network, in order to provide evidence, to collect, provide, spread the evidence about related to asthma in different places of the world. Thank you very much for your attention.
Thank you very much, Fulvio, for this kind and very complete presentation. And I think that a high number of questions is also today, it's also now still open on severe asthma. But some point in order to summarize your presentation is first of all that the uncontrolled asthmatic patients is so high in Europe also today, about 39%, and is not a low number of uncontrolled asthmatic patients. The second point is that the patients probably well know the symptoms of the disease, the clinical manifestation of the disease, but not so well the tool and the system that the medical doctor use in terms of clinical management of asthma. And in the end, it's clear that biological treatment today is an important tool for the treatment and management of our asthmatic patients. And the data demonstrate that these treatments are safe and efficacy around the world, but also today we have a high number of questions that is still open on biological treatment. And so the clinical data on real life and the other results in terms of biological study and clinical trial are essential. We have in the last 5-10 minutes some questions, Fulvio, and 3 questions are present here in the chat. The first one is, how do you assess asthma severity in clinical practice?
Obviously, the suggestion provided by Gina is relevant. The severity is related to the amount of treatment necessary to achieve the control. The topic is how we achieve how we assess the control. Obviously, we can use a patient-reported outcome, in this case ACT-ACQ, but also the lung function, the FeNO, the biological, other biological parameter. I believe that we have to use all the different tools and combining patient-reported outcome and objective measure. because not all the patients are able to provide a clear, state the clear impact of the disease from their from their perspective. In other words, there is a failure in some patients in using the questionnaire. On the other hand, it is clear that a FEV1 or a FINOR, a single tool or a single measure is not able to provide a complete pressure, a complete measure of the level of control.
Okay. I agree, totally agree with you. Is a complex system that we must use for our patient in order to assess the severity in clinical practice. The second one is what is better in case of an asthma attack, bronchodilator or corticosteroids?
Why? It is clear that in asthma attack, we have a bronchoconstriction. This means that a fast relief of the bronchoconstriction is needed. This is the reason why salbutamol, albuterol, talbutalin, fast onset beta-2 agonists are rescue medication. What we know now that is better to associate to this treatment the ICS, because it's not only matter of muscle contraction, but is matter of inflammation. This is the reason why the GIN has moved on the use of ICS pure short plus rapid onset beta-2 agonists as rescue medication. It is clear that the ICS alone is not justified, but the ICS remain the more relevant drugs in the treatment of persistent asthma. Now they associated with beta-2 agonists, if is the case with also with LAMA, because we have to use the lower dose ICS in conjunction, in addition with as mentioned, a LABA or a LAMA, in order to maintain the level of control. In the long term, the ICS is the best treatment, but is not suitable, usable as a rescue medication.
Thank you, Fulvio. The last question is this one. Are patients who are unresponsive to anti-IgE therapy prone to eosinophilic inflammation?
Yes, this could happen when we selected the biological treatment. We are to analyze the overall picture of the patients. The allergic sensitization could be relevant, but also the relationship between allergic sensitization and symptoms. You can find that when we analyze at the epidemiological level a population, we find at least 15-20% of patients sensitized to an aeroallergens, but you can find only 55% with asthma. This means that the allergic sensitization is relevant, but is one of the key points of asthma, is not all asthma. It is clear that if I have a IgE-mediated reaction, I will have a recruitment of eosinophils, but it is true also that I can have an eosinophilia without an allergic sensitization. This is the reason why the selection of the treatment must be performed according an overall evaluation of the patients. And if we have an eosinophilia, now we have a lot of drugs that are able to control this kind of pathogenetical pathway.
Thank you, Fulvio. Now we don't have some other question. I again thanks you for the very kind and complete presentation. And in the end, we wanted to thanks also Frey Company for the support to this webinar and to Global Asthma Association. And also, first of all, better, we thanks also our president, Professor Louis-Philippe Boulet, that is also the chair of GINA guidelines, because Professor Boulet worked hard for Global Asthma Association in order to provide an improvement in all the activity of this association. Thank you very much for your presence here, and again, we hope your presence and your connection to Global Asthma Association and INES network. Thank you very much, and see you.
Bye, everybody.
Bye, bye, bye.